people. All right, so thanks everyone for joining us today. This is a Cochrane People, Health Systems and Public Health Thematic Group hosted webinar. And the topic is on prospective meta-analysis in public health. We have some guest speakers here today, Lene Seidler and Kylie Hunter. They are from, I'm going to get this name wrong, University Medical Centre in Rostock and the University of Sydney. So I'll just start by introducing Lene. So Professor Annie-Lida Seidler is a Professor of Health Equity at the University Medical Centre, Rostock, Germany, Centre for Child and Adolescent Health. She is also an honorary affiliate at the NHMRC Clinical Trials Centre at the University of Sydney, honorary principal research fellow at the University College London, and convener and primary contact for the Cochrane Prospective Meta-Analysis Method Group. So thank you, Lene, for being with us today. And Dr. Kylie Hunter is a senior research fellow and leads the NextGen Evidence Synthesis Team at the NHMRC Clinical Trials Centre in the University of Sydney. She is also a co-convenor of the Cochrane's Prospectives Meta-Analysis Methods Group, and her work focuses on advancing collaborative evidence synthesis methods to address high-priority health research questions, particularly in maternal and child health. Thank you for joining us too, Kylie. And then before I get started, I'd just like to note that we are on the unceded land of the Awabakal people, and I'd like to pay my respects to elders past, present and emerging, and extend my warmth to any Indigenous colleagues who are joining us here today. And I'll pass it over to Lene and Kylie to take it from here. Thank you.
Hello, and thanks for joining. And thanks so much for having us. And please turn off your microphones. Excellent. I'll just share my. Oh, I can't share my screen yet. Let's try again. Excellent. So sharing my screen. Give me 1 second. That looks good. All right. Lovely to be here in Newcastle. We're actually all in the same room and are sorting out the technicalities of that, which is really nice. And we are going to present on prospective meta-analysis in public health today, or working together for better evidence, collaborative and prospective approaches to evidence synthesis. And we just put a few pictures of my dog here to wake you all up if it gets too methodsy. So hopefully that works. We'd also like to acknowledge the traditional custodians of the land on which we meet today. So, and we, because we like to also hear a little bit from you, we've integrated some Slido throughout. So you can join Slido either by using this QR code, or you can type slido.com into your browser and use this number. And we'd just like to hear from you for now what area you work in, so we can maybe tailor a little bit how we explain things. And there'll be some Slidos throughout to keep you engaged. So I'll give you a second. Health research infrastructure, lovely. Public health implementation science, health promotion. Excellent. Behavioral science, cancer prevention. So a bit of a mix of topics. And that's great because hopefully the method we are talking about today can be used for a range of topics. We see a lot of implementation here, and that's really interesting because that's something we are thinking increasingly about in the big evidence synthesis projects we're doing as well. So we're talking about that a little bit later on. Excellent. Now we're all a bit traumatized by this, but I'd still like to take you back to the beginning of the COVID-19 pandemic to start. These are the first few weeks when COVID started happening. And I think it was really cool to see that new trials were emerging at an unprecedented speed. So here you can see the number of trials registered each week throughout February and March on COVID-19. And at the peak, there were over 300 trials per week registered. So lots and lots of trials happening in very short time to address this new health problem. Now, the problem was, though, that most of these trials were not powered to detect differences in important clinical outcomes. So on the left-hand side, you can see the target sample sizes these trials had on average, so between 100 and 300 target sample sizes. And on the right-hand side, you can see some power calculations we did to see what kind of sample size would have been required to detect a difference in mortality, arguably the most important outcome for COVID-19. So you'd need sample sizes in the thousands, and if you wanted to look at subgroup differences in the 10,000s. So the trials were majorly underpowered to detect important clinical outcomes. However, luckily, many of them were addressing the same research questions. So here you can see the number of trials addressing the same research questions going into the hundreds or in the high 50s here. So we argue that the solution in these kind of cases would be for trials to work together through collaboration and prospective meta-analysis. So you can again see on the left-hand side how underpowered individual trials were, but on the right-hand side, you can see the anticipated sample sizes if you put all of them together, some of them in the 200,000s, so arguably maybe even a bit too large. Now, you may ask yourself, why can't we just wait for each of these trials to finish and combine them in a traditional systematic review and aggregate data meta-analysis? Why do we need these fancy new methods we're talking about today? And because, as many of you know, systematic reviews are often seen as the top of the evidence hierarchy. Unfortunately, though, they have several limitations and potential sources of bias that complicate using the evidence. So there's a few problems with traditional evidence synthesis that I'd now like to briefly take you through to then argue why prospective meta-analysis can help address many of these. First of all, we have the so-called file drawer problem. So publication bias and selective outcome reporting. Only about half of all finished studies actually end up being published. And those only publish about half of their outcomes. And this can not only lead to lack of evidence, it can also lead to biased evidence. If we imagine a full cohort study here on the left-hand side, and green are the studies that show positive results and red that show negative results, all on the same research question, we only see about half of these published through publication bias. However, most of the green ones will publish and the red ones won't. And then because of selective outcome reporting, some of the ones that were actually red will appear green when you look at them in publications. And that means that even though you had half of trials being effective in the beginning and half not, what you see in the published literature is mainly green trials. It looks like a really great intervention. You also have the problem in traditional systematic reviews that studies are included retrospectively. So usually we're experts in the fields we conduct our systematic reviews and meta-analysis in. So we actually know the big studies that we're going to detect. And that may knowingly or unknowingly influence our eligibility criteria. We like to take the example of Julie here, who knew that she'd failed history when deciding that to exclude minor subjects from her evidence synthesis and telling her mum that she was a straight A student. Just going to wait. Can you hear me now? No. We're just having some technical problems, so we're just trying to fix that. Hello? Excellent. All right, I hope you can all still hear me. I can't hear myself anymore, which is great news. The other problem we have in traditional meta-analyses is that we're often trying to compare pears with apples. So we have studies that are different in populations, outcome measures, time points, which many of you that perform meta-analyses regularly will know that sometimes you detect 20 relevant studies and then only 2 collect your outcome of interest, which seems like a major research waste. We also saw that in COVID-19. So here we looked at trials conducted in Australia addressing COVID-19 at the beginning of the COVID-19 pandemic, and how many of those collected core outcomes. And you see, even mortality, only about half of all trials collected. So if we had tried to put them together in evidence synthesis, we would have had major problems to do so. And that led to headlines such as this one: little gain is millions spent on virus studies, major research waste because of lack of collaboration and coordination. And COVID is not the only research area that sees this kind of research waste. I think many of you will know this this landmark Lancet paper where Chalmers and Glasgow estimated that about 80% of research is wasted. And these problems that we've just illustrated form a major component contributing to this research waste. So Kylie, how do we reduce such research waste and maximize the value of research?
Thanks, Lena. I think we already know the answer here. Prospective meta-analysis. This is an editorial here by the eminent Professor John Ioannidis, who recommends that all primary original research may be designed, executed, and interpreted as prospective meta-analysis. So just before we dive in, we wanted to get an idea of what your experience is with PMA. Have you heard of them? Have you done one? I'll just give you a moment to fill in the Slido now. Okay, looks like you've come to the right place because we're going to fill you in on what is a PMA. Oh, the videos.
I was working here.
Okay. Okay, cool. Great. All right. Well, we will tell you exactly what they are.
I have to click on the screen, sorry.
Okay. So prospective meta-analysis is when studies are identified as eligible for inclusion in the meta-analysis and hypotheses and analysis strategies are specified before the results of the studies or cohorts related to the PMA research question are known. So basically, studies, the results aren't known when they agree to combine their evidence in a meta-analysis. And the figure here shows the key point is that the studies need to join the meta-analysis prior to any analysis being conducted, so in their trial. So you can see the PMA cutoff here, but importantly, trials can join at any point prior to that, so whether they're in the planning, recruitment, intervention, or data collection stages. Obviously, it's best to, the earlier you join, the more you can harmonize and streamline your studies, but it's still possible to join at a later stage. And just, so today we are focusing on prospective meta-analysis, but there are very similar methodologies as well that I just will note here. So as I've said, PMAON studies are identified for inclusion before the results are known. FAME is an approach that uses aggregate data prospectively, and they look for the earliest possible timing for reliable meta-analysis based on accumulating data. Nested prospective meta-analysis we'll talk a bit more about. That's when you already have some retrospective evidence and you want to combine it with new and emerging evidence. All in is accumulative meta-analysis, so sort of like PMA with linking that with living systematic reviews. And collaborative network trials, they share a protocol, but they're a network of independent trials. So they all have a lot of similarities and overlap. So a few years back, there was no really real guidance on how to conduct a prospective meta-analysis, what they actually involved. So we, as in members of the Cochrane Prospective Meta-Analysis Methods Group, did a study where we developed this guidance, which is now published in the BMJ. We based it on a scoping review of methods papers. We looked at existing PMAs. We sought expert opinions from the PMA methods group and also used our experiences that we'd had in conducting previous PMA. And I just wanted to introduce you to a few case studies because we'll be giving some illustrative examples as we go through the steps to conduct a PMA. So EPOC, Early Prevention of Obesity in Childhood, it involves 4 Australasian trials who the trials happened to meet at a conference and many years back and realized that they were all conducting similar studies and decided to prospectively collaborate and harmonize their outcome collection. We also have Spark and Top Child. I'll just, so here is EPOC. So yeah, back in 2009, the collaboration was formed. And you can see at that point, most of the trials were around recruitment or intervention. So they published a protocol before any results were known. And then there's a bit of a period of waiting while the data collection and follow-up occurs. And then you can see later on we've published combined results. And combining these studies enabled us to have sufficient power to detect a small difference in body mass index at age 2 years in these children. And following on from this was a much larger meta-analysis top chart. And this was also looking at early prevention of obesity in children. But building on the EPOC trials, we also searched and found, identified 31 international trials that provided individual participant data. But what was important about this is we already had some retrospective evidence, but there was also a lot of emerging prospective evidence. And so we were able to conduct a nested prospective meta-analysis where we could still use both sources of evidence, but harmonize those trials that were still planned and ongoing. And that was recently published in The Lancet, if you'd like to read more. Spark, so this is synthesis using prospective meta-analysis to reduce youth's e-cigarette use, chaired by Professor Luke Wolfelden from the University of Newcastle, who's here with us. And so this is ongoing, brings together researchers from around the world to rapidly develop the research base around e-cigarette prevention for adolescents. And this is still, so we've published a protocol here. And we're at the data collection phase of this study now. So now we are going to take you through how do I conduct a prospective meta-analysis step by step, but we're going to in particular focus on key differences between traditional systematic reviews and what's different about conducting a prospective meta-analysis. And we'd also like to give you a heads up that we have recently updated the Cochrane Handbook chapter on prospective collaborative approaches. So this is under review. We hope to see it published soon, but we'll share a few snippets with you today. Back to you.
All right. So before you want to embark on a prospective meta-analysis, you need to decide that this is actually the right methodology for your research question. So I would actually like to hear from you now. What do you think, what kind of research questions should prospective meta-analysis be considered for? And I hope you don't realize that it's not good for your research question after all and will leave this webinar. That'd be very sad. Yes, I can see people. Policy questions where the evidence is emerging. Very nice, exactly. There's not much use in prospectively aligning studies if there's no evidence to align. So that's a really important point. Questions of intervention effectiveness, yes. However, I don't think this method is necessarily limited to intervention effectiveness. We've mainly worked in that space, but I could certainly see other important emerging topics prospectively combining evidence on that. And there have been some really successful prospective meta-analysis collaborations on cohort studies, for example, as well. Rare diseases, that's an interesting one. I can certainly see that sometimes it's really difficult to get enough power in one location for rare diseases, so that collaborating internationally and combining power from different trials can be really important there. Equity effects. I think certainly the idea of prospectively coordinating also means you can collect these variables and assess subgroups related to equity that maybe you would not have had the power for. So it can certainly be used there as well. Questions for requiring power, exactly. It really helps us combining more studies, getting all the studies to collect the same outcomes. So it is really good for power. New and emerging issues. I think that's a really important point. Great, thank you. So think you've covered a lot of what I was going to say. Maybe something that hasn't fully come across yet is that PMA should be considered for high priority research questions because it is a lot of work. So it needs to be worth it. And also high priority research questions are the kind of questions where we could see a lot of new evidence emerging. You'd also usually only consider prospective meta-analysis if there's limited previous evidence. If all your evidence is already out there and published, you'd be more likely to rely on the retrospective evidence. So we have this flow diagram in the BMJ publication, and I think to kind of talk you through the different steps of, is this the right method for me? One quite interesting case is here on the right-hand side, is when you already have quite a bit of retrospective evidence, but there's also a lot of important things still happening and emerging. And that's when you may want to consider a so-called nested prospective meta-analysis, where you align emerging evidence with the evidence that's already there to try to answer additional unanswered questions or add additional power, but you're not excluding the things that are already there. So exactly. So this here is kind of the nested prospective meta-analysis concept. And what you can do there, what's really nice, is you can't only harmonize ongoing studies, you can also then conduct sensitivity analysis to see whether there are differences between your prospective and retrospective evidence, assessing this potential for bias through inclusion of retrospective evidence a little bit further. The next step is to write a protocol. And here we actually have a snippet from our forthcoming Cochrane Handbook chapter that really takes you through those different steps in a lot of detail, because writing a good protocol is really key to conducting a good prospective meta-analysis project. So it can kind of help you group together those planned and ongoing studies that you want to include, and you can decide with them on key protocol elements, includes a list of the identified studies. It tells the included trials exactly how data should be collected, from outcomes over baseline characteristics, whether you're going to combine aggregate data or IPD. It can pre-specify some statistical analysis, including power calculations of when you're planning to conduct your analyses, and can decide how often you may want to update your prospective meta-analysis. So we found this to be a really key step in making sure the prospective meta-analysis really stays prospectively planned and to aligning trials to get on the same page. It can also help you identify new trials, because people may read your protocol and say, oh, I'd actually really like to contribute to that, and plan an aligned trial. How do you find the studies to include in the prospective meta-analysis, Kylie?
So again, searching for studies is a key step. And obviously this is also important in traditional systematic reviews and meta-analysis, but the slight difference for PMA, because we want mostly planned and ongoing studies. So whilst traditional searches of bibliographic databases can be useful to identify protocols, a key resource for PMA is clinical trial registries. So these need to be searched in order to identify studies that are eligible. And there we have a guidance paper, a step-by-step paper that you can check out on how to search clinical trial registers. So, and what the key differences are between your traditional, Medline bibliographic searches. And the key resources that we recommend are to search clinicaltrials.gov and the World Health Organization's International Clinical Trials Registry platform, or ICTRP. So check that out for more guidance on searching clinical trials registries. Another important way to identify studies is through your networks. So as I mentioned, the EPOC collaboration formed by chance because people were at a conference and they discovered they were all doing the same thing. So, and also you can publicize your PMA through publishing a protocol, and also via websites, research forums, conferences, and so on. So really PMA can be a catalyst for initiating a program of priority research. And whilst it can be really similar to a multinational, multi-center trial, it also allows trials, to do their own thing if they need. So you agree on a core set of a core protocol, but trials can also collect different outcomes as they wish as well. And next, we then form the collaboration.
Yeah, so this is a really important step in a prospective meta-analysis because you want people to work together and collaborate. And I think it's really beautiful because whilst usually as a meta-analyst you deal with a lot of papers, in these types of collaborative evidence synthesis, you deal with a lot of people. And these are just a few examples of the collaborations we've had and the collaborator meetings we've held. And again, a question for you. What do you think makes a successful collaboration? What may be important when trying to manage successfully such a prospective meta-analysis collaboration? Good communication. Yes, I think that's very much key to be very clear, transparent, and to really take the time as well to communicate with people. So I think one thing to really not underestimate is how much time you need to get on the same page and communicate with each other. Clear roles and responsibilities, that's really important. So we usually have a clear governance plan that clarifies all of this, that collaborators sign up to, that clarifies things such as who does what, what's expected, authorship rules, timelines, terms of the relationship clarified up front. I think that's the same, kind of having a clear governance plan, written agreement, transparency. That's of course really important, that everyone knows exactly what is going on. Agree outcome measures collaboratively. Definitely. I think that's a really important point, particularly for prospective meta-analysis, what the collaboration should be doing together. So I think it's important to see participating studies not just as data providers, but as really knowledgeable experts on this topic that have a lot to add. So we usually really try to get them involved on the protocol development and on the different research steps and interpretation of the evidence as well. Excellent. I think that's really nice answers here. Maybe I can stop talking now. What do you think?
I think
You keep going? Okay, yeah, I keep going. So this is just an example of how we like to structure prospective meta-analysis, but of course it depends a little bit on how large your collaboration is. So we usually have a steering group that does a lot of the day-to-day work, with a chair, deputy chair, some senior advisors, and a project team that really do a lot of the work. We have an advisory group where we get different people from the ground, both in terms of methods, but also policymakers, people that may implement the intervention, and clinicians. We also really like to invite consumer representatives into this advisory group to get that perspective. And of course, the trial representatives are really, really important to be on board and to be involved. And we usually have about 1 to 2 per trial, depending on the collaboration. And all these things are clarified in the governance plan, which clarifies collaboration structures, the data sharing process, importantly, authorships and responsibilities of each member of the collaboration.
Okay, so step 5 is about harmonization of study population, intervention, exposure, and outcome collection. So as Lene mentioned before, it's the whole pear and apple comparison. We see, in particularly, for instance, in our top child collaboration, outcomes can be collected in so many different ways, which, precludes evidence synthesis. So a key advantage of prospectively starting your meta-analysis is that you can agree on some core outcomes, instruments, and time points, and also, as mentioned before, enables collection of rare adverse side effects. So combining your trials enables you to have the sufficient power to look at some of these things. And importantly, it doesn't require exactly the same protocol. You can have localized outcomes as well. So just in our example for EPOC, before the trials agreed to participate in the PMA, you can see in this table on the left, the first column here shows, so there were 4 trials in EPOC, and this table, first column, shows the number of trials that collected the outcome category before agreeing to participate in the PMA. And you can see there was only 2 outcome categories that all 4 trials collected. And after they agreed, then almost all outcome categories were collected by all trials except one. So, and that's an increase, from 18% to 91%. So much more data that can be used and synthesized to answer more research questions. And of course, the ability to harmonize does depend on when your studies are included. So much easier to harmonize in what we call a de novo PMA. So when trials join the PMA at the planning stage, you have more flexibility to add or remove outcomes. Whereas if you're already at the end of the data collection phase, there's less flexibility there. So I guess in that case, when trials do join a bit later, you can still conduct some retrospective harmonization, but of course, prospective harmonization is the ideal, where core outcomes and measures are agreed and shared with planned or ongoing trials. And this figure looks a bit complicated, but it's just to indicate to you the importance of specificity in harmonizing your outcomes. So in this instance, our outcome category is child sleep. So you can have, say, 4 trials, they all collect child sleep. But then, of course, the specific variable or outcome could be sleep duration, sleep location, sleep quality. So then you need to agree on the specific measure and then also the tool. So the 3 trials might collect sleep duration in 3 different ways, with an accelerometer or 2 different questions, which may or may not be able to be harmonized. And then at the end, the method of aggregation. So some trials may provide the data continuously, which is great, or categorically, which again makes harmonization a bit more tricky. So just to be mindful when you say everyone collect child sleep, try and be a bit more specific to enable harmonization. And particularly important also for key demographic variables. So these are really important to enable us to examine health equity and precision medicine, but often they are either not collected at all or collected really heterogeneously. So things like relating to socioeconomic position, education, ethnicity are often difficult to harmonize, which is a real shame because they can help us do some great analyses. Back to Lene.
Great. So once you've done all of that and you've collected all your data, you get to the evidence synthesis and assessing certainty of evidence stage, where you get to analyze all your harmonized outcomes. And that is actually often easier than for retrospective meta-analysis because you've done all that amazing prep work where you agreed on how to do things similarly to each other. This is you can either analyze IPD, individual participant data, or aggregate data. Now, this is something you will have decided already at protocol stage together with the trialists, but I just briefly want to talk a bit more about if you decide to collect individual participant data, what that may look like. So an individual participant data meta-analysis means that instead of getting publications together, I ask for raw data sets like this shown in the right-hand side here. For each participant in the original trials. And that has many advantages. So IPD meta-analysis have been called the gold standard for meta-analysis since you really can analyze the most comprehensive and current data, including of studies that aren't published and outcomes that aren't published. So you really can get around this publication and selective outcome reporting bias. We often manage to get about 30% additional data in our IPD meta-analysis compared to what you usually see from publications. You can also do increased harmonization. For example, in Kylie's example, where you had categories, sometimes you can then go back to actually the continuous data, and you can do much more complex and sophisticated analysis. And we like to explain that using the graph on the right-hand side here. So as an aggregate data meta-analysis, you have all these really beautiful, colorful participants. Unfortunately, they get put into publications, and often all you can scrape out of them is the gray average effect estimate here at the bottom. Whereas in IPD meta-analysis, you retain all these colors, and you can do analysis such as looking at whether blue participants react differently to a treatment than red participants do. A few considerations when thinking about individual participant data and prospective meta-analysis. They're both collaborative evidence approaches. So in a prospective meta-analysis, you build a collaboration to harmonize your protocols and work together. In an IPD meta-analysis, you build a collaboration to share data with each other. So once you've already built this prospective meta-analysis collaboration, it's often easy to then also collect IPD. They also share some key features for that reason, such as how to manage collaboration and how to harmonize data. And for that reason, many prospective meta-analyses also do decide to use IPD. We've recently done a review on all IPD meta-analyses that have been undertaken, and we found that about 13% of IPD meta-analyses also are done prospectively, which is much more than the proportion of prospective meta-analysis on overall meta-analysis. So you can see that there's some overlap here. We've developed a lot of methods for IPD meta-analysis. Don't worry, we're not going to take you through all of them today. That would take too long, but we just thought it's good to point to them briefly. So it is really important to do your methods carefully for this. We've developed methods for data processing, checking, and cleaning processes, on how to do data quality and trustworthiness checks, and how to use your IPD to inform risk of bias. And all of these have been published. So feel free to check them out or reach out to us if you'd like to learn more. And I just briefly wanted to take you on a bit of a stormy side quest, which is something we think a lot about when we do individual participant data, and hand over to Kylie to just briefly talk to you a little bit about integrity, because we think it's a really important issue we've seen increasingly in recent years. This is a picture from a hike I did where suddenly I got to accidentally do a stormy side quest.
Looks beautiful. Okay, so yeah, just briefly, some of you may or may not be aware, but there is an integrity crisis in medical research. So each day there's new cases of fraud, misconduct. We had a record number of retractions in 2023. And, we've got a real problem with paper mills and all sorts of things. So, and experts estimate that more than 20%, so more than 1 in 5 published research may be affected by research misconduct. So it is something we need to think about. And just to encourage you to collect individual participant data. So this is an instance where editor of the journal Anesthesia, this is John Carlisle, he examined studies that were submitted to his journal that did not have raw data available. And almost all studies looked fine. But then when he was able to obtain the individual participant data, this changed drastically. I think around 44% of studies appeared to have flawed data. So really important to access the IPD if possible. And just briefly, if you are wondering how you can check integrity of IPD, we do have a tool available to help you with that. So we encourage you to check that out if you're interested. Okay, and back to our last step.
Excellent. And maybe just one thing to add to the integrity checking, of course, working together prospectively and along all these steps of the way can also really help you to ensure data quality is high and any integrity issues are detected and resolved early, much more so than if you're looking at things in retrospect. Now we're at this last step and we finally have published our really great paper, maybe in the Lancet like Kylie does. But we ask, should research end with publication? And we've seen many implementation scientists here. So the answer is no. We need to actually implement our findings if we want to have an impact. And I think that is something else you can do really nicely in a prospective meta-analysis framework. If done well, collaborative evidence synthesis can allow a rapid translation of results into guidelines and practice, because you're really producing that highest quality evidence to a high priority research question. However, as many of you know, there's a major research to practice gap that's usually happening. And I'm introducing a brief other example here where we've really tried to address that from the start. That's the ICOM collaboration, which looked at umbilical cord management in neonatology. So we found a really major effect of changing the way the umbilical cord was managed on survival of preterm infant. infants with a 30% reduction in mortality. We really wanted to get that into practice quickly. So what we did in ICOMP is we actually thought about implementation from the start, and I think that's really important in these frameworks. And we involved all the important decision makers in our collaboration. So we had parent representatives, we had guideline panel members included in the ICOMP collaboration, advising us on what the most important research questions were. And we had a really large network of clinicians and collaborators that were really connected in their respective countries, and we leveraged that. We also partnered closely with the major guideline committee, and we shared our results with them before we actually published. And that meant that we got our ICOMP results into the final guidelines, I think just a few weeks after publication of our actual papers, because the guidelines were already developed alongside us trying to publish our papers. And these are the international guidelines. So I think, yeah, we published in October and they got released in November, and they got really quickly implemented, and we really got all our clinicians to spread the word in their local countries as well. There's a process for how to adapt existing evidence synthesis into guidelines. It's called greater development, and that's what we worked with the guideline group, and we've actually done that for a few other studies since. So a few important considerations when thinking about implementation from the start of your prospective meta-analysis framework is to think who are the relevant stakeholders you need to engage, to invite them and consumers into your advisory group and consortium, to budget for translation and implementation. Talking to guideline groups takes a lot of time. They may want you to reanalyze everything. You have to have additional meetings. Yeah. So I think making sure that's reflected in the budget is really important, and to leverage your collaborative network, because our clinicians often knew their local guideline groups and were really able to carry the message there as well. And we go back to the Spark example, which I think is a really nice example in public health, where lots of these approaches have been combined into a living evidence surveillance system. So for the important question of e-cigarette prevention, working with stakeholders, searching clinical trial registries regularly, including unpublished information, and coordinating and collaborating.
So I think that brings us towards the end. So in summary, the lessons that we hope you've learned is the importance of really collaborating and coordinating. Before you start your research, think who else is doing similar research. Search registries, consider, can we work together? And secondly, as well, harmonizing core protocol elements and measures to make sure that evidence synthesis is facilitated. And as Lene has just spoken about, planning for implementation from the very start. And then there's a plug for you.
Yes, we do have a call for papers. And if you have heard about it now and it's quite close to 1st of March, we may be able to give you an extension. So please get in touch. We're doing a really cool collection of papers in Cochrane Evidence Synthesis and Methods around collaborative evidence synthesis. So if you have any case studies, any methods development, any studies you may want to contribute, please feel free to get in touch, and it'd be really great to hear from you and to work together on an article there. All right, that gets us to the end. Thank you for still being here with us. It's been great to present, and we're looking forward to some questions.
Thanks, guys, for such a beautifully illustrated, love the dog photos, and engaging talk on PMAs. I will open to the floor if anyone has any questions. I also have a couple back up if we're waiting for a little, but I think, oh, we've got a couple of questions already. So are trialists ever resistant to joining PMAs? And if so, do you have any strategies to encourage them to participate?
I think the key is, yeah, they can be resistant, but the key is to be collaborative and encourage buy-in from the start, so they can really have an input into the protocol. You know, you offer co-authorship. it also obviously helps if you get a lot of the other key trials in the area involved and build a really strong collaboration from the start.
Brilliant, thanks. Next question we had was from Mark is, can you comment on the inclusion or not of data other than clinical trials, e.g. cohort studies, good question, or administrative linked data, RWE in PMAs?
Yes, so PMAs also exist on other study types, and I think in theory are really well suited. The main problem we have with cohort studies is that they're not registered as frequently. So whilst for clinical trials, we have prospective registration rates that are quite high nowadays, so we have good ways of systematically searching for them. Prospective meta-analysis of cohort studies, you often really need to do by contacting people, by doing similar things simultaneously, and it's much harder to find all existing planned studies on that. So I think one key lesson is that really we should also have better systems for registering other study types. Administrative or linked data, that's where it gets a little bit tricky because, of course, I suppose you could prospectively plan to combine emerging data because they're a little bit more existing data sets. So it'd be harder to harmonize, of course. Like, how would you, because unfortunately you don't really get to say on how some of the routine data are collected, but certainly something I think that can be connected with trial data, that can be connected with cohort study data, and trying to leverage richer data sources for our studies, including IPDs and PMA, is something we've been looking into, and it's a really important and great question.
Yeah, it just goes to show everyone talk more about your trials. Next question we had was, when can you stop PMA, and does reaching power impact this decision?
So there are some really nice frameworks, and the FAME framework that Kylie talked about briefly does that quite nicely, of thinking smartly about when it is you do analyses. And that will be partly influenced by when you have enough power and partly when your funding runs out of the prospective meta-analysis. I mean, in an ideal world, what we'd do is we'd really define in advance when it is we do analysis based on when we have enough power and not before, because we don't want to look at the data too often because that introduces multiple testing. The all-in framework that we also briefly talked about has a model where you can look continuously at data that comes in, but that comes at the cost of much wider confidence intervals. So then you need to recruit more participants again. So yes, there's a few different frameworks on that, but generally what you'd want to do in an ideal case, you want to do some prospective power calculations, and once you reach that threshold, you want to do your analysis. And then if there's still questions remaining, either about the main effect or subgroups, you may then plan for your next analysis according to similar rules.
Yeah, and I think you briefly touched on it then, but any interim analysis then, I guess, is you kind of want to avoid that as much as possible.
Depending on the framework that you choose. If you're choosing a traditional framework, you want to only conduct analysis when you're likely to also find a result, so when you have sufficient power. Otherwise, it's a waste of resources, and there's all the things that come with interim analysis and early stopping. There's some frameworks, maybe also important to say that for safety-related questions, there are some prospective meta-analyses that have combined data safety monitoring, which is really cool. So their data safety monitoring boards share interim results with each other or do combined analysis early just to check for these key safety features. And I think that's in public health, maybe less often relevant, but for some clinical areas, a really cool way of working with these prospective collaborations, because they can stop earlier if there's harm. But yeah, otherwise you only want to do the analysis when you're likely to have sufficient power.
No, that's really interesting. Great point about the safety of everything too. We just have one more question. Are you still able to harmonize measures if trials are at advanced stages?
Great question. And the answer is yes, you can certainly try. And we're working on a methods paper now, which sort of goes step by step with how you can do this. But essentially, it involves carefully mapping out the measures that each trial collects and the tools they've used to collect them. What we've done in the past is we've had workshops to help us harmonise to work out if what's being collected is equivalent across trials, because obviously you don't want to over harmonize and when you lose the meaning of the variable entirely. So there's certainly things you can do, but much easier if the earlier you get to this, the better, and particularly if there's core outcome sets to encourage people to use these as well.
I've had one more question just come through. Perhaps incorporating the opportunity to be part of the PMA can support requests for research funding.
Yes.
Definitely, yes. And that's what a lot of trials do that plan to collaborate in a prospective meta-analysis. It brings us back nicely to some of the answers we've had to the questions we've asked as well. So there are research questions where it's hard to get sufficient power within the 5-year framework that most funding bodies operate in to answer those key questions around mortality, for example. And those increasingly have started working together internationally and getting their own pockets of funding, but with the promise to collaborate in a prospective meta-analysis. So we know of a few trials that have got MRFF funding here with the promise of following a similar protocol to trials in Europe or in the US, and that have worked together from the start because they know they'll have enough power once they combine their results. And I think that's a really nice framework because you can then still look at local differences. So you would see if the effect looked really different in Australia to the US, but you also are harmonized enough that you can answer these really big questions that too often we just don't have the power to answer.
And I know in our EPOC, the early prevention of obesity, the PMA, they'd use that strategy in their grant application and were able to get funding. So yeah.
It's definitely a very nice feature of PMAs, I think, getting everyone to work together and getting the funding available to do it.
Yes.
We don't have any other questions. I'll just wait another minute to see if any trickle through. But I'd just like to say thank you guys for presenting and enlightening us all on PMAs. It's a very interesting topic. Yes, just can't thank you enough, really.
Thanks for having us.
And thank you everyone for joining, and I hope you have a lovely day.
Please get in touch if you have any questions via email or